Welcome to SMA's Southern Medicine podcast. Practicing medicine in the southeastern United States presents unique challenges for healthcare professionals. The South's heavily rural population and limited resources require medical professionals to be more resourceful in their approach to providing quality care. SMA's Southern Medicine podcast addresses these issues by drawing on the experience of healthcare leaders who provide a multi-specialty, interdisciplinary team approach to medicine for the purpose of providing better care for the Southern patient population. Because heart or cardiovascular disease continues to be the leading cause of morbidity and mortality in the United States and now globally, it is appropriate that we continue to educate clinicians and citizens of pathophysiology, clinical consequences, and management of heart disease. Dr. Donald DePetty, the Health Sciences Distinguished Professor at the University of South Carolina and the University of South Carolina School of Medicine in Columbia, joins us to discuss hypertension, the leading cause of heart disease. Thank you for speaking with us, Dr. DePetty.
Well, Jennifer, it's my pleasure and privilege to do so. And before we really start with the didactic portion of this podcast and the curriculum, I would really like to extend a large thank you to the SMA for giving the time and attention to an issue as important as hypertension. Clearly, there's a lot of other things that need to be discussed. And rapidly changes every day. However, since I've devoted my career to the treatment of hypertension and as it relates to cardiovascular disease, I thank the SMA for the time.
Well, we appreciate your taking the time to talk with us about this. We believe it's a really important issue, and we're glad you're here with us to share the latest. So why don't we just jump right in and begin with, is hypertension still something that is concerning, and if so, why?
Well, clearly, Jennifer, the answer to that is a resounding yes, or number one, we wouldn't be doing this podcast. But more importantly, hypertension continues to be a major public health issue. The reason to be concerned about hypertension is, as we've already alluded to in the introduction, it is the major cardiovascular risk factor for cardiovascular disease, not only in the United States, but now globally as well. The reason it's such a big issue and such a risk factor is it has target organs. Hypertension, if left unattended and left untreated, damages major target organs such as the heart, the brain, the kidney, and our major blood vessels. And if that weren't enough, despite all our knowledge regarding hypertension and the educational programs that we've done both medically and community-wide regarding the seriousness of hypertension and the availability of safe, tolerated and effective measures such as non-pharmacologic therapies and pharmacologic or drug therapies, hypertension continues to be a major risk factor. Just to share with our audience the concerns of hypertension, it's not just morbidity, mortality, but there's also large economic and public health issues as well. For instance, we're now completely aware that cardiovascular disease globally is the leading cause of morbidity and mortality, and hypertension is the leading risk factor. So what does that mean? First of all, the prevalence of hypertension is about 33%, or about 1/3 of all adults worldwide have hypertension. That's approximately 1 billion or more people. So obviously it's a huge burden just in regards to the number of people that are going to have hypertension, and then how we're going to detect those individuals and treat those individuals. There's a cost to this burden as well. Even in the United States, hypertension costs about $370 billion, and that was in 2001 dollars. I am sure that it's exceeding that as well right now, and that represents about 10% of the overall healthcare expenditures. Wow. And more importantly, if blood pressure levels remain unchanged over the next 10 years, we will be dedicating $1 trillion globally in direct healthcare expenses. And the indirect costs are substantial as well and approaching $4 trillion. Thus, spending more money on blood pressure or blood pressure medications or non-pharmacologic therapy means we're spending less on something else. So for all of these reasons, it's important that we understand the complexities of hypertension and its important role in morbidity and mortality, as well as the global economic picture.
What causes hypertension?
Well, Jennifer, that's a good question, and it's rather complex, but we can simplify it as follows. There's two major ways you can approach the etiology or the cause of hypertension, and that's stood the test of time over the last few 3, 4, 5 decades, if you will. There's primary hypertension, which we used to call essential hypertension, and that constitutes about 90% of individuals that are going to be diagnosed with hypertension or an elevated blood pressure. And then the other 10% of individuals that have hypertension have that blood pressure elevation based on another disease state. And we call that secondary hypertension. And diseases, and this is just a general overview, diseases such as thyroid disease, both high and low thyroid cause hypertension. Kidney disease from any etiology can lead to an increased prevalence of hypertension. And also there's diseases of the adrenal glands, tumors, mostly non-cancerous tumors that obviously elaborate humoral substances that raise the blood pressure. However, it's important to note that this is the vast minority of individuals, constituting only 1 out of 10. So what we're going to be concerned with over this podcast, and perhaps even others as they're more developed, is to concentrate on the 90% of individuals, those individuals that have primary or essential hypertension. So now what causes individuals to have primary hypertension? Well, first of all, it's really a mixed bag of things. The most important thing is the genetic background. Of course, we don't have specific genetic testing for hypertension right now. We know some genes are involved, but despite all of our research, we are not there yet. So what you can use is you can use demographics. There are some patient demographics where the prevalence of hypertension is increased as well as its severity. And one demographic that becomes particularly in mind is our Black or African American population. Again, not only here in the United States, but globally as well. Lifestyle issues can also lead to hypertension, such as sodium intake. Very high intakes of sodium in certain individuals will raise the blood pressure. Weight gain leading to obesity leads to increased prevalence of hypertension, as well as the presence of diabetes.
Since hypertension is still a major health issue, what innovative measures and programs can be implemented that have been shown to increase the control rates of hypertension?
Absolutely, Jennifer. The most important thing to understand, and one of the reasons for this podcast, is we are developing innovative programs and innovative strategies to detect and to treat hypertension. However, right now, what we've been doing presently is dismally lacking. For instance, if you look at those over 1 billion individuals globally that we previously discussed having hypertension, only 14% of those individuals are adequately controlled with a blood pressure of less than 140 over 90 millimeters of mercury. Well, that's worldwide, and much of this data is contributed from low and middle income countries. And as we speak, we are working on improving control rates in low to middle income countries. But what about westernized countries? What about high income countries such as the United States? Well, I wish we had good news. The glass is half full or half empty in this issue, despite all the resources, including in the United States, that we have, all the educational programs that we've dedicated to hypertension, the safe and pharmacologic therapeutic agents, and non-pharmacologic lifestyle strategies that we have. We are still only controlling about 50 to 60% of U.S. citizens or individuals that are diagnosed with hypertension. And I would submit to the audience and to anyone who will listen that that's woefully lacking. So we must address new strategies and new forms of treating and detecting hypertension, or we're just going to be continually doing the same, and we'll be stuck at control rates of 50%. In our country, we should have control rates of 85 to 95%. And actually, that should be easily achievable. So when you start thinking about what strategies and what new programs can we do, or new therapies, whether it be lifestyle modification or drug therapy, the first thing you have to think about is what are the barriers to controlling blood pressure? What is limiting our control rates at 50 to 60% in high-income countries and 14 to 20% in low-income countries? Well, there are patient barriers, such as limited access to treatment, also poor adherence to treatment, whether it's lifestyle modification or pharmacologic therapy. There's healthcare provider barriers, such as reluctance to treat asymptomatic conditions, the lack of adequate time that clinicians have with individual patients, and that's obviously been given a lot of attention lately. There's lack of adherence to treatment guidelines, even when they're present. And more importantly, there's therapeutic or clinical inertia. And we're going to talk a little bit more about that. Then there's health system barriers. So we have patient barriers, healthcare provider barriers, and health system barriers, such as the failure to delegate responsibility to non-physicians, other team members, if you will, the inappropriate follow-up programs on patients once diagnosed, not giving clinicians feedback to reliable data and performance as how are they doing. And of course, there's issues related to pharmacologic supply and complex medical regimens that we seemingly always tend to move to. So that leads us to today. What I'd like to do, since we can address all or many of these barriers, time is of an essence. We want to keep these podcasts short and brief, but yet to the point. So today what I'd like to do is focus on several of the barriers that are targeted or attacked by one novel and innovative management program, if you will, and that is focusing on the use of combination pharmacologic antihypertensive agents, either in 2 or 3 pills, or better yet, in a fixed dose combination or single pill combination, where 2 or more antihypertensive medications are in 1 pill. But not only the combination therapy, but when you use combination therapy, and that is to strongly consider using combination therapy, fixed dose combination, if you will, in the initial treatment of the diagnosed hypertensive individual. So that's what I'd like to center on for the rest of the podcast. Let's go back to one of those barriers, clinical inertia. So what is clinical inertia or therapeutic inertia? You might hear it either way. It's the failure of a healthcare professional to initiate or intensify treatment clearly when it's indicated. So if you took 100 individuals and you said, should this therapy be initiated or intensified? All of them would say yes. And unfortunately, we're not doing that. The problem is with us. And that is one of the major barriers that's coming to light as we look at more and more reasons as to why our control rates are not where we would like them to be. So that leads us to developing strategies to overcome this barrier called clinical or therapeutic inertia. And one such strategy is to use combination treatment. And we're talking about pharmacologic treatment now. We can talk about lifestyle modification, et cetera, in other podcasts, if you will. But let's center this podcast on the concept of using 2 or more. We're going to mostly settle on 2 medications for today, in either 2 separate pills, but giving them at once, or better yet, in 1 single pill, also known as single pill combination or fixed dose combination therapy. But again, not only that, as I said, strongly considering utilizing this strategy even in the initial treatment of the initial pharmacologic treatment of the patient that has newly diagnosed hypertension. Well, you might say that that's novel and that's new, but in fact, this concept is not new. Even in our landmark U.S. Veterans Administration cooperative studies, which were done in the 60s and the 70s, when we were just trying to find out whether pharmacologically treating hypertension was a benefit versus no treatment, the VA cooperative trials used combination therapy as the initial pharmacologic approach to lowering blood pressure. In fact, they used 3 medications at once. And we all know, of course, that these studies were dramatically positive, demonstrated that lowering blood pressure, and in this case, they used 3 antihypertensive agents at once, significantly decreased morbidity and obviously long-term mortality, and has led to where we are today with our understanding of treating and treating aggressively the individual with hypertension. So this concept is not new. However, over the 40 years, if you will, it's kind of gotten lost as a strategy. We've had step care therapy and other strategies that were useful and increased our control rates. But clearly, as I've said, we're stuck. So where are we now with using combination therapy, even as the initial therapeutic choice, if you will? And we've come a long way. Several major guidelines from the United States, the Joint National Committee 7 report, and even more recently, the American College of Cardiology and American Heart Association 2017 hypertension guidelines strongly encourages the consideration of using 2 medications, even as initial therapy in patients diagnosed with hypertension. Clearly, individuals that are 20 over 10 millimeters above the goal you want to be, the guidelines actually suggest and even recommend starting with 2 antihypertensive medications, particularly in high-risk individuals. Furthermore, we know just by our data that most of our hypertensive patients, 70–80% of our hypertensive patients, are going to require 2 medications anyway. So why not start 2 medications in the beginning if that's where you want to get to? And of course, we want to increase the control rates. Our European colleagues in 2018, with the European Society of Cardiology and European Society of Hypertension guidelines, have also strongly supported using population-based strategies to increase control rates of hypertension. And in this strategy, one of the integral strategies is to use fixed dose combination or 2 single pills if the fixed dose combination is not available in the initial treatment of the hypertensive individual. So now we actually have strong support from major guidelines, not only in the United States, but now in Europe, as well as potentially globally as well. So I guess now the question is, how do you do that? What medications do you choose? What is the blueprint, if you will, to picking 2 medications versus 1 medication, which is our current strategy? And I think we should go through some of those steps. They're simple. We do not have to make this complex. And by that, let's look at the medications right now that most guidelines recommend for initial therapy, even as single agents. Well, diuretics, thiazide and thiazide-like diuretics are recommended. Renin-angiotensin-aldosterone system inhibitors, such as ACE inhibitors and angiotensin receptor blockers, are recommended as a class. And also calcium channel blockers or calcium antagonists are recommended as a class. So we have these 3 classes to choose. Well, instead of choosing 1, as we're currently doing, let's consider choosing 2 of these classes and initiate them at once. Well, you can see there's only a few permutation and combinations. You can choose 2 of these 3 medications. Having said that, what are the advantages of combining and using combination pharmacologic therapy? Well, there are several. Number 1, we've already mentioned most patients with hypertension are going to need 2 or more drugs anyway to control their blood pressure. We also know that combining medications of complementary classes, if you will, it results in additive or even synergistic blood pressure reduction. We also know that using drugs in combination, you can lower the doses of each of those agents. And while they still may be as effective in lowering the blood pressure, we're obviously noticing reduced side effects, which would improve adherence, et cetera, and costs, the overall costs of treating the hypertensive individual. Another advantage of using 2 drugs in combination is it markedly simplifies the regimen. And it reduces clinical inertia because you're starting 2 medications and not relying on the clinical provider to start 1, see the patient back, start another one, et cetera, et cetera. And more importantly, and I think this has been not highlighted enough, once you use 2 complementary agents together in a combination form, you actually lower the blood pressure equally across the vast array of demographic groups. We've spent a lot of time arguing which one medication to start with. And we started with, how do you choose that one medication? Well, what about in this, ethnic or racial group? What about in this age group or this gender group? Once you put two medications together, these issues actually go away because the complementary dual agents, if you will, lowers blood pressure equally across demographic groups, and I will show some data to support that. And finally, since using initial combination therapy results in blood pressure control quicker, more rapidly, with less office visits, et cetera, we can also have economic benefits, although I will admit the initial pharmacologic costs would be greater than using one medication, of course. However, if you look at the overall economic benefits, it might actually even lower healthcare costs and certainly would reduce fewer office visits, if you will. That would free up our health systems and our clinicians to treat the plethora of other disease states, of course, that we're seeing and that are equally important as hypertension. Another important issue is once you use two complementary agents together, such as a renin-angiotensin-aldosterone system inhibitor, be it an ACE inhibitor, or an ARB, if you will, with another agent in combination, such as a calcium channel blocker, you actually mitigate side effects of each of those drugs. You certainly lessen the pedal edema that is associated with calcium channel blockers. Obviously, the calcium channel blocker we most widely use is amlodipine. So again, another advantage is we will reduce the side effect profile of each of the drugs if they were to be given singly. Not only because we're able to reduce the dosage of each agent when used together, but also because physiologically they mitigate the side effects of each other. Another example of that is when you use a renin-angiotensin-aldosterone system inhibitor, be it an ACE inhibitor or an ARB again, with a thiazide or thiazide-like diuretic, you also blunt the side effects of each of those agents, for instance. The renin-angiotensin-aldosterone system inhibitor would blunt the hypokalemia from the thiazide-like diuretic. It may also blunt the hyperglycemia and the hyperuricemia. Similarly, the diuretic therapy blunts the potential for hyperkalemia with the renin-angiotensin system aldosterone system inhibitor. So you can see they're complementary. They're helping and they're working to help each other. So with that as a background, how do you select them? And I would like to propose a stepwise fashion to do so. In the resources that are available for this podcast, there's one recent article. It was done by myself and colleagues, published in the Journal of Clinical Hypertension just last year, that gives a step-by-step approach to selecting the ideal fixed dose or two pills, if you will, combination. And it's simple. First step is to select the preferred and acceptable pharmacologic classes you want to use. Which two classes do you want to use? Secondly, select the preferred and acceptable agent within each of those classes. And third, the proof in the pudding is you have to get the medications. Select the preferred and acceptable combinations that are available and affordable in your locale, geography, healthcare system, country, or continent, if you will. So first, select the pharmacologic drug classes to be used in combination. Select the agents within each of those classes, and select agents that are available and affordable. So with that, which two agents? Well, we looked at the various combinations and permutations, and again, there's very few of those since we're only choosing from three classes, and we divided them up. We first would recommend an angiotensin receptor blocker, a RAS inhibitor, plus a calcium channel blocker, mostly because of tolerability of the angiotensin receptor blocker. And the second choice would be an angiotensin converting enzyme inhibitor and the calcium channel blocker. A third choice would be the angiotensin receptor blocker plus a thiazide or thiazide-like diuretic. And a fourth choice could be an ACE inhibitor, if you will, in combination with a thiazide or thiazide-like diuretic. Individual agents in each of these classes, we would suggest that you choose a long-acting agent within each of the classes, as well as the CCB is easier because we're recommending amlodipine, which is the most widely used calcium channel blocker, and it's available and affordable actually throughout the world. For the thiazide or thiazide-like diuretic, we're suggesting chlorthalidone because of its long half-life and it's the greater amount of evidence-based medicine that is with chlorthalidone, or, of course, an alternative, a thiazide or thiazide-like diuretic that's available and affordable in your milieu, if you will. So if you're going to choose an ARB, choose a long-acting ARB like azlosartan, telmisartan, irbesartan, or valsartan. An angiotensin-converting enzyme inhibitor, choose lisinopril, ramipril, benazepril. Again, the common theme is long-acting once a day. So has this been tried and does it work? And the answer is yes. We have very good data to show that this works. Not only does it lower the blood pressure, but it lowers the blood pressure more rapidly and increases hypertension control rates. One of the first large organizations to choose this strategy was the Kaiser Permanente health system of North California, which consists of about 3 to 4 million individuals. And Kaiser Permanente colleagues developed an algorithm, but more importantly, the strategy of using 2 antihypertensive agents in the initial management and increase those agents and add a third. They chose lisinopril and hydrochlorothiazide in combination as the initial pharmacologic agent and stepwise increasing that combination dosage and then adding a calcium channel blocker, amlodipine, if blood pressure is still not controlled. And again, what's the novelty of this? Number one, there's a standardized and simple algorithm. We will discuss that in an additional podcast. But more importantly, they chose to use half maximal doses of each of the agents, lisinopril and hydrochlorothiazide, in a fixed dose combination and use it in the initial management of that hypertensive patient. In other words, once the patient is diagnosed with hypertension, by whatever criteria one wants to use according to the various guidelines, 2 medications were started at once. And that is really that's the major novelty of this approach. And over the last 10 to 14 years, if you will, data is rolling in. Control rates in the Kaiser Permanente group were approximately 40-ish% before this program was initiated. And now they're achieving hypertension control rates of approximately 90%. That is a dramatic increase. And again, it's far higher than our national control rates of 50 to 60%, if you will, and even the control rates within their own state, California. And again, importantly, they demonstrated that in their diverse population, that the blood pressure control rates, when you use 2 complementary antihypertensive agents as initial management, and again, stepwise increased dosage and add a third agent, if you will, the control rates are equal across all demographic groups that they studied. They studied non-Hispanic whites, for instance. They studied Hispanics. They studied Black African Americans. They studied Asian Pacific Islanders and others that were unknown, and the hypertension control rates were equal across all of these groups. Why is that important? I think it's beneficial to us as clinicians because now we do not have to argue or debate or angst, if you will, over which one agent do we have to select. Once we choose the 2 agents in a complementary class, the hypertension control rates are equal across all the various demographics, including age, race, and sexes. So learning from that experience from Kaiser Permanente, and again, knowing that the hypertension control rates in low to middle income countries are woefully low, I've already mentioned at the introduction, they're approximately 14 to 20%. The Pan American Health Organization, the Centers for Disease Control, and now the World Health Organization have embarked upon an aggressive strategy to tackle hypertension globally in low to middle income countries. That's the Hearts in the Americas program in Latin America and the Caribbean, and it's the Global Hearts Initiative of the World Health Organization globally, across our continents. Initial data is coming in from this program, and again, why is this important? the strategy, the therapeutic strategy is to use 2 medications at once in the initial treatment of the newly diagnosed hypertensive. Our first 4 founding countries, Barbados, Chile, Colombia, and Cuba, have already started reporting their initial results, and their hypertension control rates are dramatically and rapidly increasing. That is absolutely tremendous news, not only for these individuals and the populations that they're serving, but also for us in high-income countries to learn from and to watch. So again, Jennifer, in summary, hypertension still is a major cardiovascular risk factor. It attends to significant morbidity and mortality. Hypertension is only increasing in prevalence across the globe and worldwide. It's a major economic as well as disease burden. And right now, it's woefully undertreated, and our control rates are woefully inadequate given the knowledge we have, the resources we have, the pharmacologic agents we have. We don't necessarily need new agents. We more importantly need new strategies. Of course, I would welcome new agents anytime, but right now we need new strategies. We cannot keep doing the same thing over and over again. And of course, the cliche is expecting different results. And I think a program such as this, with one intervention that we're discussing in this podcast, using combination therapy, either as 2 single pills at once, or better yet, a fixed dose combination therapeutic pill, actually has now demonstrated dramatic positive results and can really serve not only our communities, but our individual patients. And after all, that's why we're all here, is to treat our individual patients, obviously their families, et cetera. And it doesn't get better than this, but it does make us open our minds, be open to new strategies, new concepts, test them, throw some away when they don't work, embrace others when they do work. And this is one of those strategies that I'm really excited about and glad to bring to our audience and to our audience members.
This has been a very informative discussion, and it sounds like that while this is a major health concern, it sounds as though steps are being taken in the right direction to combat this, and we are moving forward. And as we conclude, I would ask, is there a final pearl of wisdom, piece of advice you would like to share with our listeners?
Yes, Jennifer, and that would be for this given podcast, if you will. Once you've made the diagnosis of hypertension, and we're going to talk about how you diagnose hypertension, how you measure blood pressure, but once that has been achieved, I guess the initial pearl is, why wait? Start therapy earlier, start therapy more aggressively, if you will, and strongly consider starting therapy with 2 antihypertensive agents in the initial management of that hypertensive individual.
Thank you so much for talking with us today. This has been very beneficial, I'm sure, to our listeners, and I will refer people to our website for some additional resources that you have provided, and we thank you again for joining us today.
Well, you're welcome, Jennifer.
Thank you again for joining us. To subscribe to additional SMA podcasts, please visit sma.org/podcasts.